Welcome to Grand Rounds, and please enjoy the wonderful food that is supplied by the department. Good morning again, and before I get into Dr. Callen's CV, I've decided that of the 123 pages, if I needed some kindling later, I could use this. It's pretty impressive to actually get to read people's CVs. You know, we don't get to do that very often. And I mean, I have a few words just to describe going through his CV. One, awesome, humbling, and an astounding. He's a world-known educator, a reviewer, a prolific writer, over 200 lectures. He's got multiple named lectureships after him. We all know him really well, but one thing we might not know is when we ask about the human part of people, when I said, Jeff, what are you most proud of? What are you most proud of that you've ever done? And I thought, well, maybe it'd be something off of here. And no, it was my 4 grandchildren and seeing their faces when I can take them places. So Jeff, come up and educate us some more.
Thanks, Chris. Okay, so let's see. Let me get this up here and going. Here we go. Yeah, it's up on the screen. Okay, so yeah, it's interesting whenever you're sort of confronted with a question like that. You know, what comes to your mind, etc. I have lots of things that my wife says. Nobody actually really, maybe we don't know it. Nobody knows anything about anybody unless you actually get to know them in some kind of depth. But she says she thinks that nobody knows who I am other than, outside of medicine, because I have lots of interests, I'm interested in music. I'm interested in film. I've been involved with various arts organizations in Louisville. Last night I had the pleasure of going to a event and seeing clips of a movie that Ken Burns is directing, and Ken Burns was actually there. He and his daughter and son-in-law are working on it. And I don't know, where's Henry? Is he in the audience? Because he was in the audience last night, Henry Sadlow. The film is about Ali, and that's why they're here in Louisville. But it probably won't be out for about a year and a half, and it's an 8-hour film, and they showed us about a 41-minute, very rough clip of it last night. But then afterwards, we had a chance to hear them being interviewed by the curator of film at the Speed. It's a guy named Dean Otto. Dean isn't he's a really good interviewer. He's not a great lecturer and things like that because he's a bit hesitant in his verbiage. But the responses that Ken Burns gave were humbling. That somebody thinks that it was incredible to see how he thinks and thinks through things. Some of it sounded a little bit weird. He was talking about music and that it's not the notes, it's the intervals between the notes that are most important. I think that's a little bit strange, but it was a little strange for me. But those are types of things that I like doing aside from seeing patients and trying to teach residents and et cetera. About 2 weeks ago, when I was not here in Louisville, I was at the ACCME because I sit on a committee that reviews CME programs. They like to have an introductory. They go around the room and they want to have something just like that. They want to have something that you get introduced by. And so the topic then was what your favorite movie is. And it's difficult to pick out one favorite movie. But people went around and it began to break down a little bit because there were people who had 2 or 3 favorite movies, different situations, etc. And when it came to me, I talked about The Graduate and the line from, and then everybody was, parroting lines from the movies. And the line from The Graduate for, hopefully, those of us who are my age. Peter, you know the line from The Graduates, but it's about plastics, and that's the classic line. Anyway, without further ado, I'm going to show you about 7 cases. They involve inpatient and outpatient work. And I'm going to preface it a little bit by telling you that, yes, indeed, dermatology does occasionally come to the hospital. We don't have inpatients. When I was in training, we did have inpatients. They're probably still, I'm not sure in the US that there's any place that has any inpatients in dermatology. And the reason that it had occurred that we used to have inpatients that were psoriasis patients or blistering disease patients. We have a lot of therapies that keep patients out of the hospital now. The inpatient service for psoriasis was related to giving them light therapy on a daily basis and painting them with tar. That moved to the outpatient setting when something called diagnostic related groups came into being. If you had psoriasis, you would get 3 days in the hospital at most. And these patients had in the past been in for 30 to 42 days in order to clear their psoriasis. They would clear for months and then they would go out of the hospital. At any rate, almost entirely across the U.S., I don't think there's one service, even at Mayo Clinic, which is where the Geckerman service was developed. That's the tar and light therapy basis. Even there, I think there's not an inpatient unit dedicated to dermatology. And so dermatology becomes a consultative service. But we do come to the hospital, and we do like to see patients for complex medical problems. And I think 3 or 4 of the 7 patients that I might eventually get to showing you here are ones that we did, that either I or one of my colleagues, Cindy and Courtney, who are here, might have seen in the hospital and interacted with. When I go to the hospital, or particularly if I go to the ER, they look at me and they say, "What are you doing here?" And we don't like hearing that. We're physicians, you know. We want to help. Now, what we don't like is when if you have a patient who you're about to discharge. Anybody who's a consultant has had this happen to them, I think. And they have something that's been there for months, and it can be handled in an outpatient setting. And we get called and say, "Can you come and see this patient in the next hour?" Please don't call us for basal cells that have been there for 10 months, 2 years, 3 years, but do call us for things that are acute where we can help. The other thing, I must tell you that there are a lot of drug reactions. And if somebody said this to me the other day when I talked to them about a patient who I think has a drug reaction after being on like 7 years of infliximab that I think is related to his infliximab. And the physician said, "Well, have you done a skin biopsy?" Well, yes, we had, but that isn't the point. The point that I'm going to make is skin biopsies tell you a pattern of disease, but they do not tell you that the patient has a drug reaction or doesn't have a drug reaction. So when a patient might have a severe cutaneous drug reaction like toxic epidermal necrolysis, it will tell us that it's that pattern of disease and that it's not a blistering disease of some other sort. And we do that for that reason. But the biopsy is not going to give you the answer to what the diagnosis actually is. Okay, so I have to reveal that I do have some relationships with some industry. I am serving on a safety monitoring committee at the current time. I consulted for Arena Pharma, and I can't remember. It's about a year ago, so I'm going to be able to take that off the slide soon. It was a one-time deal, and I can't even remember what I was talking to them about. And then I do have a variety of equity holdings that are in a variety of trust accounts. I don't think that I can make it. If I could, I would like to have a change in the stock market be affected by what I say, but I don't think that it's going to happen. And until, unless I become, maybe when you're president of the United States, you can change the stock market, or if, you're a infectious disease specialist at the NIH, maybe you could change it by not having people worry so much these days about coronavirus. But I don't think I can change it. But I don't perceive that anything that I'm going to tell you has anything to do with these particular stocks that I have in various trust accounts. Henry, your name got mentioned before you got here. We were talking about the film last night, so you can tell people about it later. Yeah, it was a great experience. Okay, so what we're going to do is talk about diseases of the skin that have some relationship that have some relationship to systemic disease, and how we evaluate the patients, and then how we manage such patients. So I'm going to start with this case, which is a 41-year-old. This one's an outpatient who was sent to me by a colleague in Paducah. She first started to have lesions about 7 months before the time that we had seen her. They started on the face and neck and were then noted in the groin. She has a history of multiple sclerosis, psoriasis, and presumably psoriatic arthritis. And she was on, for her multiple sclerosis, fingolimod, and for her psoriasis and psoriatic arthritis, methotrexate and abatacept. You can see the other medications that she's on as well. So when we saw her, what we saw is this picture here, and I think I have several clinical pictures when we get up close. And then she had, you can see this is on the right, we're seeing the psoriasis behind her ear. On the left, we're seeing some of the same lesions that are on her neck, which is where they presumably started. Now, we're not doing an audience response system, but this is our differential diagnosis. The top one is what she has, which is Molluscum contagiosum. That's a pox-related viral disease. In the days that when AIDS became first noticed, we saw patients who had actually cryptococcosis, where they had giant molluscum-like lesions on their face that were cryptococcosis. So that's reasonable in the differential, as is histoplasmosis and maybe condyloma acuminata. Not condyloma lata. That happens to be secondary syphilis. That's probably not reasonable in that differential. But we did do a biopsy, and the biopsy showed us Molluscum contagiosum. So how is that related to a skin sign of internal disease? Molluscum is something that's relatively common. Kids get it. It's a sexually transmitted disease, potential in adults. But what we did was we did some blood work, and we noted that she had a slight lymphopenia. When we tested her for her CD4 count, she's in the AIDS range for her CD4 count. Well, why? And she's got a negative HIV testing, and she doesn't have syphilis. Those things ruled out some of the other possibilities. So why does she have this low CD4 count? Is it related to any of these drugs or a combination of the above is the question that we might ask. And if you look at the mechanism of action, the one that's most likely to be involved is the fingolimod, which she was given for her multiple sclerosis. But methotrexate has also been, there's been reports of methotrexate associated with widespread molluscum in the past. But in this case, we're talking about probably a combination of these agents. So what we did was to stop her methotrexate and abatacept first, because there is in existence a product that is available that can treat psoriasis, and it's approved for psoriasis and psoriatic arthritis. It's an oral agent called apremilast. It's a phosphodiesterase inhibitor, and it doesn't have any immunosuppressive effects. It's not the greatest therapy. It's okay for psoriatic arthritis. It's not the greatest therapy for psoriasis of the things that we have. But we didn't want to put her on another drug that was a drug that would alter or immunomodulate, alter her immune system. So we didn't want to go with one of our new biologic agents. Anyway, 3 months later, her CD4 count still remained low. And at that point, the fingolimod was stopped and replaced with a leflunomide-like drug called teriflunomide. That's a drug which is approved for multiple sclerosis. And at that point, her CD4 count rose, and her lesions began to spontaneously resolve. So that's a before on the left and a after on the right. You can still see there's numerous lesions, but they aren't a whole sheet of molluscum. So fingolimod, as we're going to review here, is a analog that modulates the sphingosine-1 phosphate receptor and alters lymphocyte migration, resulting in a sequestration of lymphocytes in the lymph nodes. Infectious adverse effects have been reported. A variety of infectious adverse effects have been reported, including Molluscum contagiosum. And there's one patient in the literature prior to this one. We hope that this one will be in the literature at some point. Meg Wetzel, one of our third-year residents, is working on that. And so it's something at least to consider when you're immunosuppressing patients that they might have infectious diseases. So it's a common cutaneous disease. It's due to a pox virus. Immunocompetent patients, the process is self-limited with spontaneous resolution. In adult patients, there's a sexual transmission is something that we worry about, and also severe immunosuppression. When you have widespread refractory disease, that's been commonly reported in the past in HIV-infected patients whose CD4 counts are low. But when their CD4 counts are raised with therapy and their HIV is controlled, the molluscum will spontaneously resolve. There's also a patient who's had methotrexate that has been related to that. So restoration of immunocompetency is the answer in this particular individual. Now, these cases are totally unrelated, so if anybody wants to break in and ask a question, or you can wait till the end, but I don't mind if you break in and ask a question or make a comment. This one's case 2 is a 14-year-old boy. He was seen in the hospital, I think by, I can't remember, it's Dr. Donovan and Dr. Edelman. Allie's one of our third-year residents. And he was admitted to the Children's Hospital following a sudden cardiac arrest while he was playing basketball at his middle school. He was given CPR by one of his teachers for presumably 20 minutes. The EMTs arrived, defibrillated him to normal sinus rhythm from VFib, and he had elevated troponins in the ER. He had an echo on admission that was concerning for left ventricular hypertrophic cardiomyopathy. He had cardiac MRI, concern for global infarct with a reduction of his ejection fraction. His cardiac catheterization revealed stenosis in the left main coronary artery, and a CABG was performed, and an implantable device was placed for him. So during his sudden cardiac arrest, following that, during his workup for this, the primary team noted that he had lesions on his elbows and knees. Now, he has them on more areas than just his elbows and knees. The lesions have been present since age 9, so for 5 years. And his family was told by someone that they were keloids. That's what they reported to Dr. Edelman when she went to see him. The family history was that the mother had, quote, an elevated cholesterol. Okay, this is what he had. He had these lesions on now the knees are pretty subtle, but the elbows aren't. You'll see in a minute his buttocks is not a particularly subtle lesion, but even the elbows, that's not a keloid. The knees are subtle. That could represent sarcoidosis. We've seen lesions that look like that. It could be sarcoid. This is both elbows. This is his buttocks. These are not keloids either. And this is the little sort of papules that he had on his anterior ankles or feet. And when we did a biopsy, they're just filled with foamy histiocytes. These are xanthomas. His total cholesterol was elevated. His HDL was low. His LDL was quite high, and his triglycerides were normal. And when he was genetically tested, he has 2 abnormalities of cholesterol, of genes that metabolize cholesterol, one from the father and one from the mother. So he was diagnosed as having type 2 hyperlipoproteinemia, which is a familial type of hypercholesterolemia. He was found to be heterozygous for these 2 different genes. He was discharged on aspirin, atorvastatin, lisinopril, and metoprolol. His brain MRI was normal. Following the CABG, he was anxious, and his follow-up echo revealed a normal ejection fraction. So this is from the Journal of Atherosclerotic and Thromboembolism, talking about the guidelines for diagnosis and treatment of familial hypercholesterolemia from back about 3 years ago now. An amazing case that I think if someone had recognized the lesions and biopsied them earlier, maybe would have been prevented what happened to him. But fortunately, a good outcome. We have some that aren't such good outcomes. I think that I'm not sure in this class whether I'm going to show them to you or not, but This one's one that we had to go, that I had to go to the hospital. I think it was just after the 4th of July. This was an old case, so it was when John Edge, who's one of our now clinical faculty members, comes in occasionally and does dermatologic surgery with our residents, teaches them that, saw. And it's a 61-year-old man who presented to the emergency department because of a presumed worsening cellulitis. For those of you who remember, I don't remember if it wasn't our last grand rounds, maybe it was 2 grand rounds ago, we had somebody talking about cellulitis and pseudocellulitis. This is one of those pseudocellulitis type patients. Anyway, he had been seen in the ER despite IM and oral antibiotic therapy. He wasn't responding. He had a 2-week history of progressively worsening redness and edema, subcutaneous nodule formation on his left leg and thigh, and basically he was diagnosed as cellulitis, given intramuscular ceftriaxone. He didn't respond, so he was put on oral doxycycline and cephalexin. He continued to worsen. He had no constitutional symptoms, no local symptoms otherwise, and he got admitted to the hospital. Well, he had a past medical history of having had a squamous cell carcinoma of his tonsil, which was treated with chemotherapy and radiation therapy. His social history is important because he was divorced. He lived with his mother and sister, but he prepared his own meals. And he works full-time as a supervisor at a security agency. He denied alcohol or drug abuse, but his dietary intake was purely canned chicken noodle soup. And he had a particular brand of canned chicken noodle soup that he was interested in. So when we saw him, he was afebrile. He had this intense, I'll show you the pictures in a minute. He had intense erythema that involved his left leg up to his knee. You'll see the lines that people like to draw on patients when they think they're following cellulitis. They'll be present in his pictures. But he had perifollicular purpura, which was present on his abdomen and thighs. That give it away. Everybody know what perifollicular? I know that our residents and the derm people know what perifollicular purpura implies. And then he had these little hairs that kind of curled around. Anybody yet? Okay. So you see the surgical marks, that were drawn on his legs, and then we get up close, and he has these little things that are called corkscrew hairs. Anybody yet? Scurvy, right? It still exists. People who you'll see the people who are at risk. So he's anemic. His vitamin C level, when it was measured, was essentially non-existent. Chicken noodle soup, the one that he was drinking, happens to contain no vitamin C. So what happened was we saw him. I was pretty sure he had scurvy, and I asked Dr. Edge to take a biopsy. And what I did was I went to the supermarket and I examined the chicken noodle soup that he was drinking while Dr. Edge was doing the biopsy, and I found that his chicken noodle soup was not enhanced with any vitamin C. Anyway, when we put the patient on vitamin C, within a rapid period, you'll see the follow-up picture. This is the before and after, and it's taken only about maybe less than a week apart. And his cellulitis has completely resolved with appropriate therapy that wasn't an antibiotic. It was a vitamin. Yes, probably so. So vitamin C is a cofactor. It's you don't need much per day. 10 milligrams intake would prevent scurvy. And the people who are socially isolated men, so even though he's living with his mother and sister and he's cooking his own food, we've seen scurvy in people where their spouse dies. They're the ones who are responsible for doing the cooking, and now they're not eating things and we see it in alcoholics occasionally. They also will have problems in with their gums and dentition and have swollen, beefy areas, bleeding gums, etc. And the corkscrew hairs are, to us, that's a giveaway. When we say corkscrew hairs, that means to us essentially, and perifollicular purpura, that means scurvy to us. Okay, so the fourth case is a 73-year-old woman. This is one that Courtney has seen. She dragged me in and I saw the patient as well. But this is an outpatient, not an inpatient. But it's a woman who was seen with an eruption on her arms in August of this past year. She'd been previously seen for a similar eruption almost 12 years prior which had been diagnosed as subacute cutaneous lupus erythemus due to calcium channel blocker at that time. And then in 2010, she'd had a papular eruption on her neck and trunk, which was diagnosed as mucinosis. At that time, she was on leflunomide, which has been related as a trigger of subacute cutaneous lupus as well. She has a fairly full past medical history, but I'll just point you to the fact that she has rheumatoid arthritis. She has probably Sjogren's syndrome. Not clear if she has lupus. But people say that you have lupus and rheumatoid arthritis that overlap. Some of the people will use the term lupus. It's in the literature. I don't know if it really truly exists. But some of the patients have secondary Sjogren's who have rheumatoid arthritis. They have antibodies that relate to that. At this point in time, this lady had been started in July on a new drug, Abatacept, July of 19, and she'd had 4 subsequent infusions and was just continuing to worsen as she was continuing to be infused. So her lesions is an annular erythema that's in a photo distribution. Courtney Schott took these pictures at the time, I think the day that we were seeing her together. And our differential diagnosis for these annular lesions is listed here, but I've already told you and alluded to the fact that this is subacute cutaneous lupus. So which of the following tests are not needed in such a patient? And the answer is that we really don't need to do, probably really don't need to do an anti-Ro antibody because we know she's positive. She's been positive in the past. But that's the one. We did do a skin biopsy, which shows an interface dermatitis. This is probably as good an interface dermatitis with epidermal atrophy and then lymphocytes that are coming up right along the, let's see if I do have a pointer here, I think. This is the epidermis, and then we have this little vacuolization of the basal layer, and then we have lymphocytes that are hugging this epidermis. We call that an interface dermatitis pathologically. So she was Rho and La positive. She has a high positive anti-nuclear antibody, and she's on a variety of drugs. Now, the lisinopril can cause lupus. It's pretty rare that ACE inhibitors do that. Omeprazole and all of the PPIs have been linked to subacute cutaneous lupus and exacerbating it. And if you substitute one PPI for another, they recur. So if we tell you we think a PPI has done this to a patient, the disease itself isn't life-threatening. You know, it's aggravating. The patients hate it, but it isn't life-threatening. So if a PPI was a must, you could do it. But if you can do something that is not a PPI, that's preferable. In this case, though, the newest drug is Abatacept, and when we think about drug reactions, we want to think about the newest drugs. Well, then we go to the literature and we look up and see, has Abatacept ever been reported to exacerbate subacute cutaneous lupus? And indeed, it has. So this was a report that appeared about 2 years ago now in one of our journals, and shows you the before and after the Abatacept was taken away. Oops, sorry about that. Go back. So there are lots of drugs which give you this pattern of disease. There's probably over 100 drugs. The most common ones are antihypertensives, terbinafine. That's an antifungal that people have used for nail fungus. And the PPIs have become very common. Also anti-TNF agents, calcium channel blockers, those have been triggered. About 30% of the patients who we see that have subacute cutaneous lupus have a drug that's triggered it or has exacerbated it. None of the drugs in and of themselves have a high prevalence. So, you know, if you say, well, PPIs are really common, they're over the counter. We don't go around every day and see a case of subacute cutaneous lupus from PPIs. But when you do, and you take it away, you don't want to give them another PPI. You don't want to give them back the Abatacept. You want to give them some other agent for treating their disease. It differs from, this drug-induced cutaneous lupus differs from drug-induced systemic lupus. The drug-induced systemic lupus have has very infrequent abnormalities on their skin. It has serositis as the most frequent problem, either pleuritis, pericarditis, or joint aches, sometimes fevers. And serologically, it's different. Drug-induced systemic lupus has been linked with antihistone antibodies, although antihistone antibodies are rather nonspecific, whereas drug-induced subacute cutaneous lupus is linked to the anti-Ro antibody. Having said that, you don't have to have an anti-Ro antibody be positive in order to make a diagnosis of drug-induced subacute cutaneous lupus. It can be negative in patients, and we can still make that diagnosis of drug-induced disease. We don't know if this is true or not, whether you should in some way avoid some of these drugs that trigger it in patients with known photosensitivity or known LE. But the management involves withdrawing the drug and then either a short course of corticosteroids. The disease goes away. You have to wait a number of half-lives before the disease goes away. And so I reported several years back, we reported a patient who had adalimumab that had caused drug-induced subacute cutaneous LE, it was golimumab. It wasn't adalimumab. Both of them have been reported. We reported golimumab, and that's one which has a much longer half-life. And so in that patient, we had to add in antimalarial agents, and then eventually we took the lady off her antimalarial agents because the disease did clear. And there are those patients where the drug seems to awaken the disease, but then it never goes back to sleep. And so then we have to, treat them more chronically for taking care of their subacute cutaneous lupus. Okay, the fifth case is a patient who's a 44-year-old man. He has a 2-year history of a diffuse pruritic scaly eruption with hair loss, perifollicular spiny and keratotic papules. We saw him, he was sent to our office as an outpatient. He's being followed by organ transplant recipient group. I think, Reno, let's see, who does who's running that transplant clinic these days? Yeah, I think that's who sees this particular patient. And the patient had a organ transplant for diabetes, and he had a kidney pancreas transplant because he had diabetes and hypertension, and he had it about 7 years previously. He has hyperlipidemia, he has hypertension, he has peripheral neuropathy, and he's on a variety of medications that would be predictable. And he had been treated previously with topical corticosteroids and intramuscular triamcinolone, which is a corticosteroid, for a presumed diagnosis of what they were calling psoriasis-like dermatitis, psoriasiform dermatitis. So when we see him and then Megan Hulsman, one of our recent graduates, she's one of our volunteer faculty member who just joined us this past year. She was a medical student here, and she was did her PGY1 year here several years back before she entered her derm residency. So it's probably about 5-6 years ago that she was, I think when she was a medical student, her last name was Holtgrave, but she's called Hulsman now. She was the one who saw this patient, did the biopsies, and then brought the patient to our conference. And what you see is a widespread sort of ashy coloration to this African-American man's skin. He has some lichenification. That means there's an enhancement of the folds. It means he's itchy. We don't have to ask him. If he says he's not itching, we know that that the history is not, I don't want to say that he's lying to us. It's not quite that, but we know he's rubbing because when you rub the skin, you enhance the skin markings, and you can see that in the antecubital fossa on each side, that the skin markings are enhanced, and so it's a bit thick. So when we biopsy it, we're going to know that we're going to see a thick epidermis to some extent. And when we get up close, you can really see the enhancement of the skin markings. That's not normal. It doesn't look like ichthyosis, though. It doesn't look like just simple xerosis. It means he's itching. Or perceiving burning or something. He's manipulating his skin to get to this place. Then he has it on the back of his neck. there's some subtlety to it. And sometimes when we see velvety changes on the back of the neck, we think about insulin resistance. I'm not worried about that in this particular man. We know he's a diabetic. If we see that type of change just on the back of the neck or under the arms, we do worry about insulin resistance. But you can see he's got, he doesn't have alopecia like I have, but he's got this sort of diffuse thinning of his hair, and his hair had been, I think, much fuller in the past. When we start looking at his hands, he's got these really odd-looking spiny papules within follicles. They're also on the palms. And a close-up. These I don't think you can miss. These are little keratotic papules that are follicularly based. Okay, so what does he have? This is the differential diagnosis that we might create. Arsenical keratoses doesn't seem reasonable. I mean, this is a new onset. Arsenical keratoses would look like what he has on his palms, and it's more from people drinking well water or having taken. There used to be therapies long ago. There was a thing called Fowler's solution, which was given to people who had asthma and eczemas. And we have a dermatologist in Louisville who's retired now, but as a kid, he was given arsenic as a therapeutic process, and he has these keratotic lesions on his palms. And there's well water that contains arsenic in the area, and so some people have had those little scaly things on the palms, but that doesn't fit with the rest of his process, and it's not acquired. Keratosis follicularis is another name for a disease. It's a genetic disease called Dermatology disease. He doesn't have that. The skin lesions that he has don't look like Dermatology disease. Acrokeratosis paraneoplastica. That's a condition that was described by a French dermatologist. I don't know how you say his name. It's B-A-Z-E-X, so Bazek, we say, but probably not the right pronunciation. I never, Spanish was my second language, and I was poor at that. But French is not, I know how to say, I can say escargot. I know the T isn't said at the end, but getting people's names correct, I'm not sure I do well. The other thing, now, plasma cell dyscrasia. There are some patients who have paraproteinemias and have myeloma, and they develop these little spiny perifollicular lesions that are on their nose primarily, but they can be acral as well. But they don't get this widespread pruritic dermatosis. So it doesn't fit with that. And then so we're left with what's up there on the bottom, which is called pruritic dyskeratotic dermatosis. However, it doesn't fit with that because those patients are widespread psoriasiform or lichenified dermatosis with alopecia, but those patients don't tend to have the spiny papules. So it doesn't fit with anything that's there. It sort of overlaps between 4 and 5, okay? Okay, so he gets biopsied in 2 places. And this is the biopsy from his right shoulder. It has acanthosis, that's thickening of the epidermis. And when let's see, this change that we're seeing here, this is why he has lichenification. He's got thickening. I mean, his shoulders shouldn't look like this with all this scale. And then he has a little bit of dyskeratosis and a little bit of melanin incontinence of pigment. This is the acral skin, and the acral skin has this verrucous acanthosis keratin filled, so it's a spiny papule. So how do we put this together? Well, I've already told you what the diagnosis is. It's this thing. I think this is the best diagnosis that fits. So what is this entity? Well, one thing is this can be new to you because it's kind of new to me, and it's kind of new to the literature even. And so what we did, this is a disease which is related to polyomavirus. And in this case, it's been related to polyomavirus 6 and polyomavirus 7. And so I happen to be friends with a guy in Houston who is interested in skin diseases and viral diseases and has a lab that does testing. And so we were able to send him paraffin-embedded tissue and ask him if he could look at various polyomaviruses. And what he's done, he's got a control on the end, and he's got the top tray, which is human polyomavirus 6, then the middle tray, which is human polyomavirus 7, and he's got specimen 1 and specimen 2. Specimen 1 is, specimen 1 are our skin biopsies. Both of them are positive for human polyomavirus 7. And then he also measured another human polyomavirus, which is called trichospinulosis polyomavirus. That's what's responsible. That's a virus that is responsible for those spiny perifollicular papules that occur in patients with plasma cell dyscrasia. So our diagnosis that we're working with, but it doesn't exactly fit, is that he has this relatively rare disease. It's a rare clinical disease. I think there's only been maybe about a half a dozen patients reported in the literature with it at this point. It's related to either 6 or 7. They have the PDD, as it's abbreviated, as a itchy pruritic, brown to gray, lichenified plaques that involve the trunk and extremities. That fits for him. The infection can be either 6 or 7 primarily, and it affects the epidermis with a sparse involvement in the upper dermis. I already told you, trichodysplasia spinulosa. It's another cutaneous disease. It's seen with that specific polyomavirus in immunocompromised patients with plasma cell dyscrasia. And it's characterized by spiny papules, as I've talked about, that involve the face, ears, extremities, and trunk. Sometimes they have lichenification, but he doesn't have that virus. He has 7. So there are 13, at this point there are 13, who knows how many there will be eventually, that there are 13 distinct polyomaviruses. There are several diseases that are related. There's a BK polyomavirus, which causes a nephropathy, but less commonly can cause ureteral stenosis and hemorrhagic cystitis. So my guess is that you guys who do renal transplants see that maybe sometimes, I don't know. The JC virus is one that we worry about. All of those of us who put patients on immunosuppressive agents worry about having a patient develop progressive multifocal leukoencephalopathy. And we put patients on, rituximab for pemphigus. It's an indicated process. But those of you who use rituximab for lupus, or who use rituximab for lymphomas, you might worry about that as a potential problem. Those are people who use mycophenolate mofetil. It's listed in the package insert for that, but a variety of immunosuppressives do that. Merkel cell carcinomas is a form of non-melanoma skin cancer, and that's related to a different polyomavirus, which is called the Merkel cell polyomavirus. And so because we have a target, there may be a therapy that would be directed other than just surgical, particularly if they have metastatic disease. And then the TS polyomavirus I already talked about with trichodysplasia spinulosa. Okay, now we got a transplant patient. We're not going to reverse that. We're not going to take away his transplant organs. He's not going to be able to live. We don't really want to change his immunosuppressive dosage much because that might affect the viability of his transplanted organs. And then there have been reports in the literature of using topical cidofovir, but he's got disease that is so widespread that this would be cost prohibitive. Oral cidofovir, I think, has a variety of toxicities. I'm not sure we want to use that. And there is one report in the literature of using oral acitretin. Acitretin is a vitamin A derivative. It's approved for use in psoriasis. This would be an off-label use for it. So there is no known effective management, but there's only been 7 or 8 cases in the literature, or a dozen cases in the literature that have been reported. So this particular patient, let's see if I think back to our patient, yeah. So this is the 5th patient with PPD, but he also appears to have these little keratotic papules. What we're going to do to him, I think he has been started now on acitretin, and then topical cidofovir has been used in another patient. We're not going to do that. Steroids have been ineffective. Antihistamines have been ineffective. And so maybe I'll come back in a year or two and say that the acitretin worked, or we'll present them at another meeting and somebody will tell me something else that might work for this patient. Okay, our sixth patient, I think we'll stop after 6 and then we'll have some time for Q&A. Maybe I'll see what the seventh one, how quickly we go through this. 77-year-old man. He was first seen in November of 2016, and he had a 6-month history of a patch on his right lateral lower abdominal wall. It was presumably occurred while he was receiving radiation therapy for prostate cancer. And this was the initial pictures. See, I try to tell. This was taken by one of our physician assistants who was the first person to see the patient. I like pictures to be taken when patients don't draw, they're not drawn on. But we do like to know where biopsies are taken. And so this is the picture is available in the chart. It's not somebody that I saw until later. And so they indicated where they took the initial biopsies. So the differential diagnosis was lichen sclerosis versus radiation dermatitis. A biopsy was performed. The patient was told it was consistent with a radiation dermatitis, and emollients were suggested. He came back a month later. Triamcinolone was prescribed. 2 months later, a basal cell was treated, and triamcinolone was continued. And in August of 17, I think that might be, he was seen again, and triamcinolone was again considered. In November 16, this is his rather nonspecific biopsy showing a little bit of edema in the epidermis and a thickening of his skin. So when I saw him, he said that he was, November of 17, I don't think that was when I saw him yet, he was supposedly better with therapy, but in the physical exam, they stated that he had this patch, and they gave him a mixture to use. But the patient never used it because he never picked it up. It's too expensive. And that was his picture in November of 17. So he presented to me with recalcitrant disease in April of 18. This is past medical history. He has a number. He's had a problem with phimosis. He can't pull his foreskin back. And he had a circumcision, but it wasn't done as a circumcision. Trust me, he has a foreskin present. They didn't completely remove his foreskin. So his circumcision wasn't done well. And he'd been using triamcinolone on the abdomen and clotrimazole on the penis. Well, this is what he looked like when I saw him. He has more widespread disease. He has a whitish discoloration, and when you felt it, it felt like somewhat like sandpapery sort of a feel to it. And when you look at the surface of the skin, it looks like cigarette paper. For those of you who are old enough to have rolled your own, you know what cigarette paper looks like. And you get that wrinkling of the skin, and it's somewhat hard. And so we examined other areas of his body and found that under his foreskin, he had these white patches. I didn't take a picture of that. And I repeated his biopsy, and his biopsy shows this really looseness to a thinness to the epidermis and a very looseness in the upper layer of the dermis. So he's read as a sclerosing dermatitis. That's all you really need to focus on. You don't need to read the whole of the report. It's just there, and they talk about a whole differential. But he has an overlap between lichen sclerosis, which is a superficial form of scleroderma. It's related. It's a localized process. It is not systemic sclerosis. And morphia, which is a localized form of scleroderma. So we prescribe that. We treat that with clobetasol ointment. And we did that, and you can see the benefit that he had. You can completely get the process better with an ointment. So this is a radiation-induced localized scleroderma type process. It occurs not that infrequently. I've seen it at least in the last couple of years. I've seen it in 2 different patients, so it's not terribly infrequent. This is a report of just radiation-induced lichen sclerosis that was. It's a table that's out of a report that appeared in JAMA Dermatology. People have looked at this, and this one that's in the Journal of the American Academy of Dermatology looked at 22 patients. It extends beyond the radiation field many times, and there is a good response to either phototherapy. You can give them topical intralesional steroids, or you can give them methotrexate. That's something that's also been used in some of these patients. So some people think that you shouldn't radiate patients who have a history of a variety of rheumatic diseases. I don't know if somebody calls and asks me about it, I think if they need radiation therapy for a cancer, I think they should have it. I don't think they should stop because they've had a history of dermatomyositis or systemic lupus or particularly localized scleroderma they would be asking me about. When you see a lichen sclerosis, the other thing is we have to look at the genitalia. If it's a woman, their genitalia, the vulvar lichen sclerosis is not an uncommon disease, but people don't tend to look at it. They tend to look at only where, my colleagues, and we don't necessarily look at the genitalia. I don't know if you all in doing your complete physical exams are looking at genitalia, but I think you should be. I think patients should be undressed fully and disrobed when they're having an annual physical exam. I have a bias, I suppose. Let's see, okay. Yeah. Guess we'll quit there, I think. So thank you for your attention. Questions, comments? Dept. Well, it'd be an interesting thing to, if we had somebody who wanted to come over to your clinics where you have all those patients and examine them, we could do some kind of survey or something like that. I don't know, the problem from our standpoint, we only see the patients who get sent to us. So they have, it's like, they have skin lesions. We don't see many patients who don't have skin lesions. Peter. And maybe it'll tell. The thing about it is maybe it'll tell us something about the pathogenesis of some existing diseases that we can then treat more effectively. Hopefully. Now, one of the things I'll comment on, you talk about polypharmacy. Patients are not really good about taking their medications. So our polypharmacy that we think they're getting may not actually. They may not. Smarter than we are. Yeah, maybe. I don't know. We think that we're, but then, and then the other thing that comes up, I was staffing clinic at the VA yesterday, and let's see, Laura Taylor, who was an intern with you guys last year, but was working with me. We had a couple of patients, and you get the electronic record, and it pops up with a drug interaction that the patient might have. Knowing what drug interactions are actually true and are important. Maybe it's true, but is it important? And then again, are the patients actually taking the drugs? So, but that's been an incredible thing that we don't go by. I don't go by a day where I'm prescribing something and it tells me there's a potential interaction. I'm going to prolong somebody's QT level with my low doses of antihistamines. I don't know. Hopefully, I'm not going to cause sudden death. Henry. Yeah. Yeah. So that case, we're still working on getting that case published. I think it's probably going off to like cases in American Journal of Medicine. We tried for a pediatric journal, and they didn't want it. But American Journal of Medicine has a nice, it's the old green journal, I think is it still green? It's not still green, is it? It's still green? Yeah. I remember it as the green journal. Anyway, they have dermatology cases in it, so maybe they'll, I don't think we've sent it yet, but that's where we hope it's going. Um, yeah, it's one of those that, now the question is, what part of the body did the pediatrician actually examine? I think my experience with when my kids and even now my grandkids and what I've seen, my daughter's a pediatrician, what I've seen her do, they actually take clothes off, as opposed to, I have been to, unfortunately, I must say that I've been to a couple of internists where they did not disrobe me. I don't go with them. You know, I went to one relatively recently, and I say, "Don't you want me to take my clothes off?" And the response was, "No, I kind of do that on another visit. You know, we have this first visit." I didn't like that. You know, I mean, I'm old school, I guess. I don't, you know. Yes, yeah. You can probably listen okay that way. Maybe the physical. Maybe I'm just an old fogey, and the physical exam isn't important anymore. I kind of think it still is. You know, I do think I think that patients on an men on an annual basis ought to have sorry to say, a rectal exam. You know, you need to feel the prostate. I mean, that's the way I learned it. I don't know. Um, and we all, and unfortunately, in medicine, I'm talking about generalists, but in medicine, we all become parts doctors. So I can't remember. I don't do rectal exams in my office. You know, I think if I started to do that, I'd probably be reported to the board of medicine or something. But and I don't expect cardiologists are going to do it. But a generalist, I think, on an annual physical exam. Now, for a woman who goes in and they have a gynecologist, and the gynecologist does an exam, and they don't have prostates to feel, so they probably don't need that issue. But when I don't know, there was supposedly some, that you could feel with your finger the rectal cancers. I don't know if that's true or not true, but
Your finger is.
yeah. Yes, Lynch syndrome is a familial cancer syndrome, and the thing that comes to mind most is let's see, the MSH. It's Muir-Torrey syndrome. They have those patients get squamous cells, which are often rapidly growing, and they also get sebaceous gland related tumors. So sebaceous adenomas, sebaceous carcinomas, and not so much sebaceous gland hyperplasia is very common. So we don't think of Lynch syndrome in those patients. The Lynch syndrome patients have a propensity to develop colonic carcinomas, and the men and women can get bladder cancers. It's an autosomal dominant, so if you diagnose somebody with Lynch syndrome, their family members need to be assessed in some manner, or they should be assessed in some manner. Yes. Yeah, so the purpura that's perifollicular is very distinct. And the purpura that you would see in like a capillaritis that's a benign condition is not perifollicular. It can be follicular, but it's also non-follicular. It's not like that. And then palpable purpura, where we're worried about a vasculitis, an actual inflammation of the small blood vessels, is not perifollicular at all. It may be exacerbated under pressure areas, but it's not perifollicular at all. Good questions.
Thank you.